Welcome back. You know, it's interesting when we try to make this active and interactive. Panel discussions can bring out some ideas because they just flow. I mean, we don't know which direction it's going to go, and they just build, and they always seem to come up with really rich information. And that was no different than the panel we just had on culture. This was actually an idea that came out of a workshop we did in Waco last year on health literacy, and we had this panel to talk about what were the roles of the different disciplines in terms of communicating with patients. So these questions were developed by Brian Dodd, he was a director and founder of the Potter's Vessels Ministries. It's an organization that helps people face healthcare challenges, looking for resources and coordinating different types of care in the Waco area. We have 3 panel members, and I'm going to let them introduce themselves.
I'm Lee Grumbles, and I'm an assistant professor here at the University of Texas Medical Branch. I do training for the fellowship with the nursing homes and the skilled nursing facilities. I oversee the home visit program, and I also am board certified in hospice and palliative medicine.
My name is Patti Creighton. I'm an occupational therapist. I've been an occupational therapist for about 28 years. The last 9 years I've worked in geriatrics. And I've worked in a variety of settings with a variety of patients, and I think over the years I've learned a few tricks in learning how to communicate with people, and so hopefully we can share some of that today.
My name is Meredith Mizell. I am a social worker and research fellow at UTMB. I'm the social work curriculum coordinator for the ETGC, and I'm the social work consultant for the Lance Armstrong Foundation. I review their educational materials for cancer survivors and their families. And my research is in minority health and aging.
Okay. And in Lamar University, we have Nancy Bloom.
Yes.
Nancy, want to say a few words about yourself?
Yes, I can. Thank you for including me on the panel. Today I'm going to represent nursing home aspects of that. And I wanted to tell you, I do have some gerontological background. Not only am I am one, but I also coordinated an interdisciplinary geriatric program at another university where we had folks from a lot of different disciplines getting a minor in gerontology. And I'm certified in gerontology as a nurse as well.
Thank you, Nancy. Okay, there's a note coming through. What could this be?
SFA.
SFA, okay.
Tell them to back it off.
Smiley face.
There's a smiley face. Do we need something?
I don't think they can hear us.
I don't know.
Really?
Because they're trying to communicate that
Yeah.
I'll be right back.
visually instead of auditorily.
We're good, Tony. We're good.
You good?
Oh, they're good
Mark?
now.
Okay, good. All right.
Got it fixed.
All right, we're taking care of all the technical issues.
Somebody talk to them.
See, moderators wear a lot of different hats, don't they? Okay, okay I sent out these questions, and they're in your handouts. And I'm going to just state the question, but what direction it goes, we're just going to see how that works. I'm going to start with Dr. Grumbles here, and then move down, and then we'll just go from the other end on another question. So this first is to describe the effects of poor health literacy that you have personally observed in the lives of geriatric patients and clients. And I'd like to also keep in mind of health literacy from their being adequate to achieve health literacy from the health provider's point of view as well.
Well, I guess the most common thing that I run across with health literacy problems is the fact that many families normalize memory defect, and dementia to them is something that's normal. They don't see dementia as a disease process or as a cognitive defect. So it's as if their culture as it is has normalized dementia. So I have a real hard time many times educating and making people recognize and understand that I'm diagnosing a disease process and I need to treat or at least assess a disease process, and they don't see it as a problem because it's normal to them. So that's probably my biggest challenge, I think, that I've come up against, the most frequent challenge that I've come up against with health literacy problem in the elder population.
Good. Patty?
I would include that, but I would even add just activity and participation in daily function as part of that too, because I think what happens a lot of times when older adults come into the hospital especially, or they become ill, the family starts doing everything for them. And a lot of my job is to educate the patient and the family about the importance of still allowing and encouraging the person that is in the hospital to do what they can for themselves so that they don't lose their strength, so that they don't lose function, so they don't lose that desire to continue to be independent. And so that's probably 90% of my job as a therapist, is to try to encourage them to keep doing for themselves.
I think the biggest thing that social workers may come across regarding the effects of poor health literacy in the lives of their geriatric patients is a poor understanding of the medical nature of depression and other psychiatric like illnesses. This can be, this is something that can really impair the relationship that a social worker has with their patient. Also, complaints about health are more prevalent, I think, in practice among those patients who lack or have poor health literacy.
Nancy?
I wanted to speak a bit from the nursing perspective. One of the things that we see happening, of course, is that we're taking care of more gerontological folks, and with the increase in the number of chronic illnesses, we're seeing issues with patient safety and even in taking care of folks in a home health setting, that nurses often do. So we have particular standards that we have to meet in terms of our practice area. Some of those being just lately implemented come from the IOM. And so we have to pay particular attention to safety. And what we're saying is that many of the errors that occur in terms of, for instance, patient falls and all of those kinds of things may be problematic from a literacy point of view. How do the elderly folks interpret some of those kinds of things that we have to do for safety? And so I think those are the kinds of things that we see in nursing, particularly are the effects of poor health literacy.
Thank you, Nancy. Since I'm going to minimize the amount of camera work I have to do, I'm going to start with Nancy on this next question and then move back the other way. So, Nancy,
Yes.
while there's probably a limited amount of time available to do any assessment of the level of health literacy on patients that you may see or clients, do you do any assessments? Are there, besides some standard tools that are available, are you able to do some observation or some kind of assessment of level of health literacy on your patients? And if you do, what types do you use?
Well, I think besides general forms of gathering assessment data, which nurses use all of their senses to collect data in that manner, I think we practice from an evidence-based practice foundation. So one of the things about best practices is that it reflects the evidence that shows that you're doing the right thing and the best thing for the patient. So we do use standardized tools a lot in assessment. I don't think we have one specifically that we include in all aspects of nursing just yet, from the LVN clerk to the advanced practice person. But we are cognizant of the fact that you do have to use different methods of collecting assessment data to reflect what a true health literacy pattern might be. So we could be talking about things like observation and listening, and those kinds of skills and assessment.
If and we can do this with the whole panel as a follow-up to that, because that's a really good point that, you know, there's not just assessment tools and observation, but if you come across an outcome, for example, you know, compliance of medication isn't being quite followed, and that might be related to the ability to understand, to take the directions, read the labels, things like that. Are those addressed maybe with a follow-up visit, and if, you know, and is that something you might see, you know, now and then among patients? So, Meredith?
I've never used formal assessment tools to assess health literacy of a client, but generally I think that it's important to remember that it's not just vocabulary use and educational background. While those are very important and can lead you to think that someone might have poorer health literacy, I think the most important thing to try to note and elicit from someone when you're initially meeting with them is a lack of awareness of their own health issues, and having more specific discussions about what their own health issues are can help you as a social worker determine their level of health literacy. Because, you know, I know there are probably a lot of people in this room who have maybe an older parent or relative who has a good educational background, but you could roll your eyes when you listen to them talk about their, you know, their visit to the nurse practitioner. So anyway, I think awareness is the biggest thing for me.
Okay.
I guess this is a question I could spend the most time on. As a therapist, I do look at a person's physical, cognitive, and emotional abilities and where they are with each of those things. And I guess I always ask my patients, do you understand why you're in the hospital? What are you here for? Why do you think the doctor ordered occupational therapy? Or why did you come to the emergency room in the first place? And many times what I think I'm going in there to talk about is not at all what is important to them. And I'll even say, you know, my goals, what I do for you as a therapist is not something I do for you. You have to be actively engaged in what we're doing, and it has to be meaningful to you. And so I always ask the question, what is it that you have concerns about? What is it that you would like to be able to do, or that you want to know more information about to be able to help you be healthier? And that opens up a whole can of worms usually, because what I actually go in there to talk about is usually not what we wind up talking about. And that is especially true if, like Dr. Grumbles has been in there before me, and the patient's been told that they have a terminal disease, and you know, there's really nothing more the medical team has to offer them in terms of a cure or really getting better. And then I go in, and I think it's still important that I go in and talk to them about how they're handling that information and what concerns they have about that. Because they may not understand what the doctor just told them, or they may give me an example of what they thought they heard, which is not really what I understood Dr. Grumbles telling me what they just told the patient. So we can start in a common ground there and develop a plan for them to be able to cope with what is going on with them. But first, I think it's important that you understand what they are understanding so you can meet them at their level, because otherwise, no matter what you say, it's not going to have much of an impact, because they're not going to be able or ready to hear what you're trying to tell them or what you're trying to do with them.
Well, I can just reiterate what Patti just said, because the most important thing that I try to teach my young physicians practicing with me is to always evaluate what the patient and the family knows. So anytime I start a patient encounter or a family meeting, one of the things I always do is tell me what the young doctors have explained to you is going on right now. Because that's going to let me know, one, where they are on their health literacy scale, and or get measured against what I feel like their health literacy scale is. Two, young doctors are horribly optimistic. And so with me practicing palliative medicine, lots of times I'm coming in really with a different story. in a different line than what the previous doctors may have actually said to the patient. So by asking the patient and the family to tell me before I ever give them any information, before I give bad news, before I talk about treatment options, I say, tell me what you know. What have the healthcare providers told you? And then that gives me the information then to try to frame what I need to then respond to them. If I realize there's a very low health literacy and they do not understand what's wrong with them at this point in time, I can't go on with talking about options and medical decision making, because they have to understand their disease process and their problems and how these disease process and problems are going to impact them before they can move on to making any decisions. And that's a step that many times doctors miss. They want to go in and they want an answer. You have option A, B, and C. Choose one so I can go on outside and write your orders for A, B, or C option. In actuality, with people with poor and limited health literacy, you can't do that. You have to ensure that they were literate enough to understand that health issue and to make an informed decision about their healthcare decisions from it. And it takes time and it takes effort. Sometimes multiple visits before you really feel like they get to the point where they're understanding and comprehending and able to validate the impact that their decisions are going to have on their lives personally.
Great. This next question, I think, speaks, I want to try to get at the actual different roles that the different disciplines play within the interprofessional team. For example, whether on the ACE unit or in some place working with an older patient. So, how does the team communicate with each other? For example, if someone may realize that I'm really not getting through to this patient. So, what approaches can be applied to patients that you see with low levels of health literacy within the framework of an interprofessional team? Lee?
Well, another thing that I try to do and teach my physician learners to do is anytime they give a patient something that is confusing, some information that is confusing or information that can be perceived as bad news, I always tell them before they leave that unit, they need to go to that primary care giving nurse for that patient for that day and explain the conversation that they've just had. Because you give bad news or you give confusing information to the patient, the first person that patient is going to ask something of is the nurse. Because when that nurse comes in to check their vital signs, to check on them, to administer a medication, the first thing out of their mouth is, the doctor said this, or I didn't understand what the doctor said. And so I think it's very, very important that when the physician picks up on that the patient or the family didn't quite get the point we were trying to get across, that we warn the nurse who's caring for that patient that day to be on the lookout, because she's probably going to get some more questions and she needs to be prepped on what the conversations were before she goes back into that room.
And that's between the physician and the nurse?
Between the physician and the care providing nurse of the shift that day when that information was given.
I think one of the real important things...
Go ahead. I found comments. Something moves you.
I just wanted to reiterate that's an excellent point, Dr. Reynolds. Nurses do need to be aware of what the doctor tells the patient so they can reinforce that. Research shows that nurses spend probably more time, about 3 times as much time in the actual care process with the patient than the physician. So they are the ones who should be able to answer those questions for the patient. And some of the principles that you talked about in earlier sessions about communication with the elderly, I think can be well applied here, and you reiterated some of those already. But I think that the communication with the physician and the whole team is something that maybe we can work to improve. And unless that's documented, perhaps the nurse in change of shifts doesn't know what went on prior to that. So we could do some better work in improving communication among ourselves so that we have better outcomes for the patient.
It's a really good point, Barbie. As far as the Nancy, what happens when there is a certain change in what's maybe not expected with the care team, the disciplinary team. So that I'm really glad that was brought up. Patty?
I was going to say, I think one of the most important things we do on our acute care for elders unit is our daily rounds, where everyone has nurses, doctors, therapists, social workers. Each person has an opportunity to explain or express what their concern is about that patient's discharge and about their care. And many times the topic may come up, for example, the patient's non-compliant with their medications, or they're just not taking good care of themselves at home. And as a therapist, those things really pique my interest, because I may go in and evaluate the person and find that their vision or their dexterity has some limitations, and that may be, or maybe their cognition, they've got memory problems. And all those things may have something to do with their ability to take their medications and take them consistently, or be able to take good care of themselves with getting up and fixing themselves something to eat. So other concerns that other professionals bring up, I can actually go in and assess some of those areas and then come up with interventions that will enable that person to be able to do the activities they need to do to be more compliant with their overall treatment plan, which will help them to understand and be more literate, I guess. The other thing that I think is important is that the person, the patient, and the family understand how them doing one thing or not doing one thing can lead to further problems. So if they're in the hospital and they're going to be there 3 or 4 days and they choose not to get up and walk around, or they choose not to let the nurses give them something to eat or drink if they need help with that, explain to them how that's going to affect their ability to improve or to get stronger. And the importance of what they do today, how that's going to affect them tomorrow, and then 6 months down the road when their goal is to go back home. If they don't get out of bed today and if they don't eat and drink something, that's not going to be a feasible goal for them. And sometimes they don't understand how not doing something one day is going to have a consequence later on, and just helping them to understand that.
My perspective is not as much part of an interdisciplinary team. Unfortunately, when I practiced social work, I did mostly home visits or one-on-one assessments. So my approaches are going to be kind of in a different area than what everybody else has been talking about. I think some of the most effective things when dealing with someone who has low levels of health literacy are very simple: sitting, engaging in eye contact, being sensitive, involving a relative in the discussions. One of the things that I thought was the most effective that I ever did was encourage a client to write down what I was saying and recommending, and then reading it together and going over it together to look for holes or anything that was mistaken or missed. And I said this once, but again, engaging a family member can be very, very effective and helpful.
Nancy, is there anything else you'd like to add to that, on that question?
I wanted to build upon the last comment. Part of what we do in nursing is a lot of patient teaching, and a lot of that discharge as well. So the techniques that you talked about, reaffirming and reteaching, I think are across all disciplines of patient care, and certainly those strategies to make sure that the person understands the process of their disease, what's happened to them, and what's expected of them in terms of self-care when they go home, are all aspects that can be addressed through those basic kinds of reaffirm and reteach, and find out what they understand.
Okay. The next question looks at more or less opportunities and barriers that can be used to improve geriatric health literacy. based on maybe what you see within the healthcare system. The healthcare system, as you probably know, is pretty convoluted, a little complicated, I'd say. And maybe that's a barrier, and maybe there's a way of getting around that. But how can you see the ways that we might be able to improve on the healthcare system to help the patient work through it? Nancy?
Well, I think we're not the only ones addressing improvements in healthcare at the moment, but I think that we have to use, well, a technique that we call in nursing is it has a theoretical basis of modeling and role modeling, and it's a theoretical principle that we use in nursing. But that means getting to view the client's world through their eyes, and if we take the time to really do that, I think that's where good communication and good education initiates. The problem that we have continuously is the push to get more done with fewer resources, which limits time with the patient. So I don't know how to solve that.
Meredith?
In social work, that's called starting with where the client is, and it's one of the first things they teach you in school. And it's difficult to do, but that is important in this area. The one thing that I think the social worker can do, an opportunity or a barrier and an opportunity at the same time. The barrier is that there are so many different types of medical professionals that a patient comes in contact with. If they are not under the care of a geriatrician or a consistent team, helping to streamline their health care, helping them streamline their own health care really is with, and helping them take control of the how much jumping around they're going to be doing from physician to nurse practitioner to therapist is one thing that social workers can do to improve their patients' health. And I think that another barrier are safety concerns for older adults. We have a lot of times this can lead, I think, health practitioners to put stereotypes upon older adults, and so starting where the client is, like Nancy said, is something that we need to do.
Two of the big barriers I run into are lifestyles. For example, we may have someone come into the hospital with diagnosis of dehydration or mental status changes and maybe something else going on, but come to find out they're a really big alcoholic. And we know that more than likely when they're discharged from the hospital, they're going to go home and start drinking again. Well, over the years, I've kind of addressed that a lot of different ways, but now I just go ahead and I say, all right, we're going to talk about something. You may want to tell me the truth, you may not want to tell me the truth, but I need to ask you this, and I need to give you my recommendations and ideas. And we'll talk to them about their drinking. And depending on how I approach it, usually they're pretty open and honest with me. And I just explain to them, right now you've got, for example, a real problem with your balance. You are at risk for falling and coming into the hospital again with a fractured hip or a head injury. I said, if you choose to go home and continue drinking, that you're going to be even more at risk. And just explaining to them again the consequences of some of their actions. And understanding that they may or may not even listen to what I'm saying, let alone make any changes in their lifestyle. But I feel like I need to say that as a professional. The other issue, a barrier that I really run into, are those patients that are at that transition stage of not being completely cognitively intact, which maybe none of us are actually, and being to where they can't make decisions for themselves. They're somewhere in the middle where they're making unsafe decisions and perhaps they're not really aware that they have cognitive deficits. And in my assessment, I'm able to give them a score of how much at risk they are for being able to take care of themselves and do that safely. And I will try to explain that to them and or their family, that many times they're at that transition stage where either they don't care that they have that problem, or they're not willing to hear that that's an issue for them. And so regardless of what the outcome is or what my findings are, they're probably not going to make any changes with how they're doing things. And so that's a real barrier for me. And the other obstacle I have because of all those things is, as I work in an acute care setting, I may have the opportunity to see that person over a period of 3 or 4 days. And what information I find out and what I'm willing to share with them is probably not going to make a whole lot of difference if these are things that have been going on for many, many years in their lives. And so that's a big obstacle, being in acute care and trying to make some impact on their lifestyle and on their independence. So I think one of the solutions to that is to have a real cohesive team, so that the social workers, the nurses, the doctors, we can all reinforce the same information at the same time. And then also having good follow-up, whether it be coming to the outpatient clinic or coming to see the physician at their next follow-up visit, and that physician understanding what some of the issues were that were identified during that acute care hospitalization. Perhaps recommending they have home health for a home safety evaluation so someone else can go out into the home and yet again reinforce some of those findings of what some of the issues are as far as safety or mobility or cognition. So just having not just intervention in one setting, but having it across the board, and there being good communication so everybody knows what's going on.
Well, I think the biggest barrier for the physician segment is that they feel uncomfortable saying something that is not to the nth degree true. As physicians, we're trained on a subcellular, pathophysiological, knowledge base. And when we're talking to someone with a low health literacy, sometimes we're going to have to describe something that's not going to be absolutely to the letter of description of correctness with pathophysiology. And I see physicians struggle with that all the time because they feel like, well, if I explain this on the simplest level where they're going to understand it, I'm not going to be giving them the correct information. So they insist on giving them an explanation at a level that they can't ever understand. And they struggle with the fact that it's okay to change what they know as absolute scientific truth and just have that truth reinterpreted in a way that can be understood by someone with poor health literacy. But I see physicians struggle with that day in and day out, and it's not just my young physician learners. I see that with people that have practiced and have experience with all types of people across all walks of their life. I think it's something we as physicians feel like we can't lie. We can't, speak a mistruth in any way. But I feel like sometimes for health literacy's sake, we do need to be able to get over that need to be absolutely correct with every word that comes out of our mouth.
Now it's time for a curveball. No. I have one question left, but it brings up an interesting point I was just thinking about. And if there's just dead silence after I ask this, I'll just ignore it and we'll just go to the next question. But I guess I'm just thinking, in terms of the opportunities to overcome a barrier of health literacy, that there are a lot of different mediums out there in terms of how to do it. Whether it's verbally or you give written information, to a patient, and like this is kind of what's going on. For example, I had a busted eardrum, and the doctor I went, he just printed out a whole bunch of things about the tympanic membrane and all these things about the treatment and how it works and the anatomy and everything. Are those the kinds of tools or something like that that you can also use to just make things a little easier to understand? And is that doable? Maybe there's a time issue or something. If you find that you can't get through maybe in one way with language, where maybe something written could help with that.
I do that a lot with hospice, because if you remember when we talked about delivery of bad news, we said the receiver of the bad news only remembers about 15% of what they're told. So lots of times for certain patients, I will provide them with written information of the important stuff. Now, for most of my patients, my geriatric patients, and for many of my end-of-life patients, I don't print out the normal stuff that comes off the internet that, you know, someone with a college degree is going to be interested in reading. Lots of times mine is much more simplistic because I'm wanting to get I want them to learn and to understand the really big basics. And then once we get those really big basics at that next visit I have with them, we can start expanding on that knowledge base. And even with someone with poor health literacy, if I give them the basics, they're usually going to go out, the majority of the time, they're going to go out and they're going to talk to people, they're going to read, they're going to ask some questions. When they come back to me, their health literacy is already taken a step higher on that ladder rung of health literacy. And so then at that point in time, I'm able to take and give them a little bigger bite, a little more specific bite about, you know, really what's going on, more intricate bite of the information. But I use a lot of very simplistic, in fact, to the point of being overly simplistic. And many times I apologize to people. I tell them, I'm going to give you this stuff, and this is going to maybe read and sound very simple, but these are the most important things I want you to learn and remember before you come back with me. And I'm not trying to insult you with this, but these are the most important things, and so I'll give them that information. Just a little bite of information.
We use a lot of handouts, a lot of pictures, a lot of written information because our patients do get a lot of information in a short period of time and they need something to refer to when they get home or to share with their family. I think this pertains to nursing as well as therapy, but we do a lot of talking, but we don't just talk. Many times a patient, you'll talk about the importance of getting up and moving or how they're going to have to adhere to certain precautions after hip surgery. And they understand a little bit about that, but unless you actually have them do something or attempt to get up or try to go to the bathroom and clean themselves or try to go stand at the sink and brush their teeth or try to change their colostomy bag, they're not going to know whether or not they can do it. They may very much think, oh yeah, I'm going to be able to do that just fine. Or the family may say, oh, well, yes, of course I'm going to be able to take care of mom, even though she needs pretty much total care. We actually have them do that while they're in the hospital. And then we can intervene and see what they do understand, what they need help with. We give them an opportunity to say, you know, you were right, I really don't feel comfortable with this. But it actually, hearing what they're going to be doing, what interventions we can help them with, what education we can give them, and then them actually trying it under our observation and assistance really helps a lot towards their understanding and then their ability to carry over with that once they leave the hospital.
I was just going to add one thing, that handouts can be very helpful, especially frequently asked question style handouts. Though often if the questions can be written in ways, the way people really talk, those can be of great use to patients who have low health literacy.
Nancy?
One thing that I wanted to add, people learn in three domains: cognitive, affective, and psychomotor. So what I'm saying really supports what you said before. But if we could get people to value and believe in a certain way of doing things, for instance, in health promotion, and so that would be the cognitive aspect, or excuse me, the valuing aspect. Then the cognitive would be that they would have to think about that, and then they would actually have to do that or repeat some kind of motion activity skill to reinforce it. So I think thinking about that with geriatric folks is something that we can fine-tune and not just expect that printed material is going to be the way to do that. I was interested in also in, there are a lot of, well, for instance, support groups in some Alzheimer's areas are using online support groups now, but we can see that there's probably only a third of the elderly population who even have access to computers and use them on a regular basis. And one of the things we neglected to mention under the barriers was income and finance. And I think we talked a bit about that in one of the previous sessions, but tying those things together.
I had one other comment. I think the health literacy that a patient and or the family demonstrates in the hospital setting does not necessarily completely translate into the health literacy at home. I think it's two very different environments, and it's very structured and very supportive and very pristine, so to speak, in the hospital. When they get home, Katie bar the door, all kinds of things can interfere with that. And so we have to be real careful that if we have them, if we think that they're pretty literate and pretty understanding and pretty compliant with what they're doing in the hospital, that does not necessarily mean that that's going to be the scenario at home. So we need to be aware of that.
Great. Our last question for the panel. Now this is probably a little bit more on the philosophical side, which is always a decent way to kind of end something. Because I think we've looked at some very practical ways of improving health literacy that are done or wish they can be done. So what organizational values, and I'm thinking of that in terms of also ethics, can you draw towards improving geriatric health literacy?
Well, I think one of our organizational values here at UTMB, you saw a little bit of it today. UTMB is a very culturally diverse university, from patient population to our medical students, our allied health learners, our physician faculty, our staff. And I really believe that part of health literacy, a big part of it, is just recognizing all those different cultures and being aware of them, and then being willing to adapt what you're speaking to and speaking of to people in a language and in a manner that they're willing to hear it. You know, if they're not willing to hear what I say in my language, then I need to figure out how I'm going to say it in a language. And when I say language, I'm not speaking in the true definition of language. And I mean in a way that they're going to be receptive to hearing what I have to say. So I have to read my patients and then change how I communicate individually from person to person. And I really believe here at UTMB, our mission to be diverse allows us the ability to improve our health literacy with our populations because of that recognition and that respect that we have for diversity.
This is a tough question. I think for me, understanding that there's some patients I'm going to be able to reach and have an impact on, and there's other patients that I'm not. And I feel like I have to compromise a lot, and I guess that's just part of what we all do at work. But if a patient's family is really wanting to help that patient and do a lot for them, and it may be that the patient, that's kind of what they want, that's their goals, then I may have to compromise my role. That's not really a good word, compromise. I may have to modify my intervention with that family and that patient to help them to be able to meet their goals of providing good quality care for their loved one when they get home, but at the same time trying to eke in there a little bit of patient participation, so they're working on improving their independence and maintaining their strength. So I think understanding that you do have to modify what you want to do and what the family and or the patient's willing to do, and coming to an agreement there so that it's a win-win situation.
Social work values include dignity and worth of the person and the right to self-determination, and I think those are the two big things that would draw me toward improving geriatric health literacy. If we can give a client or patient the tools to achieve their own self-determination and control over their health, that's the best we can do, really. And also recognizing inequality in services to those who might not be might not have good health literacy is important. You can't forget that. And just as a side note, I wanted to make a comment about what you said about not being able to take the care plan and bring it home because home provides its own set of barriers. That's when I think the other health professionals should just talk to the social worker. The social worker can discuss with the patient the barriers that are in their home environment that may be there, that make following through the care plan difficult. And they can work through some of that before they leave the hospital perhaps, or even at home if there's a home visit. Sorry to add that.
Thanks, Meredith. Nancy?
Yes, I think there are three things that we need to look at organizationally to help improve health literacy. First, that nursing and all members of our panel have been dedicated to, but we need to say it, is the improvement of patient outcomes. If we can improve health literacy, then indeed we can improve health outcomes. I think commitment to health promotion and prevention of the second kind of organizational structure or function we need to have in place. And certainly in the medical area, nursing area, we have moved dramatically in that direction. And the third thing I think that we need to see organizationally to change health literacy is looking and committing to the change in demographics. And certainly your institution has done that by developing the Geriatric Education Center.
Good plug, Nancy. I like that. I'm putting that in the brochure. Excellent, thank you. And well, you know, and the closings always seem, you know, those are all, you know, I think it really kind of comes together in terms of, you know, of covering a huge amount of information and material in a short period of time. But this kind of format seems to work for that. So we're at the end of this session, and we have a few minutes, and I do want to ask for a couple questions. But before, well, yeah, in fact, let's do some questions first, okay? So I'm going to open it up to the audience and to the other audiences hundreds of miles away to ask some questions to the panel if they'd like. Anybody here? James.
Okay. How much is it? Some background. Glenn was playing with medical decision making up on the H unit. And some of the little pilot data he got, there was such a discrepancy, race, ethnic based on how much patients actually wanted to know, how much they wanted to be involved in the care decisions. And I don't remember which group did what or the other, but how much of health literacy is volitional? Is how much, you know, like when you go to a mechanic, you don't want the whole, you just want it fixed. And so there's certain subsects that want to know that you as the physician or the therapist know what you're doing and tell me what I need. You weigh how much they want to know. You know, it's basically the discrepancy in where they want to be and what they know is the illiteracy part to me. And so do you take that into account, or are you just trying to get everybody so educated that they can be accountable?
Good question.
I ask them what they want to know.
Yeah.
I'm a big, all my learners will tell you the thing that comes out of my mouth constantly with my learners is ask the question. If you feel uncomfortable or you don't know the question, answer the question, ask the patient. So you ask them, you know, how involved do they want to be? I have patients literally that when I talk about advanced directives, they empower me to make the decisions. They say, Dr. Grumbles, I don't understand enough about disease and what happens during, you know, the end of life to know what I need to be doing, but I trust you. And so they empower me to actually make those advanced directive type decisions for them. Now, some doctors feel like that's appropriate, and some doctors feel like that's not an appropriate task for their PCP to do. But once again, I ask the patient and have the patient let them know whether they want to be involved with that decision making, whether they want to turn it over to family, or whether they want me to paternalistically make decisions for them.
I kind of also, as part of my standard discussion at the end of what I've said, or maybe even at the beginning, I'll say, well, what questions do you have about your ability to go home and take care of yourself? Or what other concerns do you have? Maybe there's something that you're wondering about that nobody's even talked to you about yet, and you'd be surprised at some of the responses you get to something like that. But that's what's really important to them, and if you don't ask, you may not find out. And then that may open the door to being able to discuss a lot of other things that really everybody wants to discuss.
Are we all answering?
No. This is a general.
Oh, okay.
You don't like my
If
question?
anybody has
No, I
something to
don't,
say. Any other? Yeah, Sue?
It's about the medical decision-making data collection tool that we used on the ACE unit. And it's sort of like the previous panel, the two gentlemen on this end were saying there's such a variation even amongst culturally, ethnically homogenous groups that when we're up on the ACE unit asking those questions, it's all over the place. I don't even know that. I could say there's a pattern in how people make their health decisions. And you kind of get that feel when you interview a patient what they're going to say, but to me, it's just all over the place. So much variation.
It's important not to impose your beliefs about what someone might be like on them. There are definitely more within group differences than between group differences. And so sort of releasing preconceived notions is something that can really help you get to where you need to be with a client, patient.
Any questions or comments from the other sites in Lamar, Baylor, SFA, Victoria?
Yes, from Baylor.
Yes, okay.
This is Howard Gretzner, and this is a comment to Dr. Grumbles when she made her initial comments about dementia, frustration. I think in a way what is happening with dementia care, whether you look at it strictly from the medical system or other systems, we've actually got a condition that creates a kind of health literacy no matter where people are illiteracy, no matter where they're starting out. First of all, most of the people I end up seeing, if they're diagnosed, they're given the label dementia, which is, by its very nature, ambiguous. So we've got to do what we can, where there is the basis for it, to at least connect it to a disease process. Because then we can begin to work with them understanding the basis for the changes they see. The other part of that I think supports the fact it represents a kind of health illiteracy is that in order to manage what's happening to a family members themselves have to learn to completely reframe so much of what they're seeing that was another set of patterns of behavior that they lived with most of the life of that relationship. So there's a huge amount of change. And that change cannot be dealt with successfully unless they have a chance for a lot of education and exposure to problem solving that utilizes that.
I totally agree. And one of the things that I see over and over that happens in the elder population with dementia is that lots of times the family does not accept, recognize, or intervene until something catastrophic happens. And then you're at this horrible crossroads to try to provide education and support because you're dealing with catastrophic events at the same time. So I totally agree with you, and I think it's very important that we recognize and try to get this upstreamed before we do have catastrophic events occur.
I think research tells us that in a crisis situation, maybe you hear what's being said in the first 15 seconds, and after that you don't.
I think, too, with dementia... I was going to say, I think too, in relationship to your question about dementia, it is a continuum, and I think that that's an opportunity for us in the hospital, for example, or even in the doctor's clinics or outpatient therapy clinic, to kind of see where they are then and help the patient, and maybe most importantly the family or their caregiver, understand that that condition may continue to deteriorate, and being able to problem solve some different solutions before they have to actually be implemented, but just so they'll know what some of their options might be.
Yeah, I'm with the Alzheimer's Association, but my background is geriatric mental health for many years. So I'm able to do counseling and work with families and the patients, but if you think about it, there are not that many people or not that many systems that exist that respond to families that way. So we really need to find ways to develop resources that are more family or patient-friendly to help them deal with this long progression that you referred to.
One thing that we do in this community, a lot of the local churches, there's a local place like an adult daycare called Libby's Place. We continuously do community in-service and education seminars to families and their caregivers and patients and just the general public about dementia and some of the intervention strategies and some of the things to look out for and some compensation strategies. So there is a lot of opportunity for just general community education to get that word out.
Okay, any other questions, comments? I've asked the panel if they would like for any closing remarks or take-home messages. That's always a nice way to end. And I'd like to say, Nancy, anything that you'd like to say that really moved you, or there's some take-home that you might want to bring up?
The only thing that I wanted to mention in closing is that we all need to learn to speak a common language. We use a lot of acronyms in healthcare, and certainly when we learn to better communicate with the elderly, will improve their health literacy immensely if we can speak the same language.
Thank you.
One thing I wanted to mention, since we have a lot of different healthcare providers in the rooms, is that because you may only have 10 or 15 minutes or less with a patient, it may drive you up the wall when you have a patient come in and sit down and open up a piece of paper because they have a list of questions. It may have been the social worker that told them that they should do that to help them remember all the things that they need to do to control their health. So try to be sensitive to that. Even if you next time you see somebody do it, just check yourself for a minute and think, okay, they're trying to take control. This should be the kind of patient I like,
Blame the social worker.
Yeah, blame the social worker.
I think this is something everybody realizes, but even though I'm getting closer to geriatric age, I am not in the same situation they are, and I constantly tell them that. I'll say, I don't really know how you're feeling, what you're going through, but I know this, and maybe I can share information about your disease process, about what can potentially happen, what some recommendations are, and then you can take what you know about your own condition and we can come up with some kind of a plan. But I really have to stop myself a lot of times and understand that I'm not where they are. I don't have the life experiences, the values, the pain that they're having, and it really makes a difference because they do have that, and they have to take what you have to offer and what they're already experiencing and somehow mix that together to come up with their own plan.
Well, what my take-home message is that physicians are inherently horrible communicators, and we just need to accept that as a fact And with the way we do medical education, we're not going to change that for probably 2 or 3 generations if we ever manage to change it. So I think it's real important for people to understand and for physicians to understand that they have to use their interprofessional group because, you know, our nurses, our social workers, our therapists, they're all much better communicators. We have evidence-based medicine that proves that. There's, you know, evidence-based research out there. And I think we have to realize what our deficits are as a profession and start really pushing and teaching that, well, with what our deficit is, we do have a interprofessional team that can make up for our deficits. And so I think it's really important to know how to use your interprofessional team and let them help you with what you're not good at, which is communication.
Okay. Excellent. So ends the 5-month session on health literacy. I feel like I'm sitting by the fireside here. To close this up. And how do I do that? Well, I think for a session that really didn't know what was going to happen and how it was going to start out and how it was all going to end, I do believe that for the 5 months that we've been meeting to talk about health literacy, that we have hit on some really salient points that are really important to remember. And I would like to encourage anyone out there to use maybe what's been learned, disseminate it to others who haven't been able to be here, talk it up a little bit, and be very, very aware, if you're not already, about the importance of communication, empathy, being aware of diversity of different cultures, all the components, because we spent 4.5 sessions, how many hours, talking about the components of what health literacy might be or might not be, and the factors that can affect it, and one part of a session in terms of what to do about it, in terms of how to improve it. I'm hoping to look at the next advanced sessions on this topic in January to really explore more on what we can do to improve the level of health literacy, because it really, obviously, is so important in good health outcomes for the older patients, for all patients. So I thank you for your attendance and your comments and participation. I thank the panel members. I'd like to give them a big round of applause. Nancy and Lamar, thank you for participating at such a last minute. It was perfect.